Now we have Dr. Vineetha who will be presenting on OCT angiography. So everyone have OCT, but in this era, that OCTA is one thing which actually helps
Hello.
when people don't have fluorescein angiogram, because all the vascular plexus of the inner layer, and this is actually useful for the diagnostic and prognosticating the diabetic macular edema. So Vineetha will be talking on OCTA, a helping hand.
Thank you, ma'am. So, okay. OCT as a helping hand in diabetic macular edema. Now, OCT angiography is a non-invasive imaging modality used to visualize the retinal and the choroidal vasculature. It is basically dependent on the laser reflectance from the surface of moving RBCs. We take sequential scans along the same line. Then you analyze the difference between these scans for points of constant points and moving points. The points of movement are identified as flow, and all these points of flow are aligned together to create a vascular image. That is what we see as OCT angiography. Now, what are the advantages of OCTA over a conventional FFA? First of all, it is non-invasive, much quicker, no dye is required. Then, as there is no leakage, you get good structural detail of the vessels. 3D images are possible, unlike the 2D images in FFA, and you can segment into slabs. That is, the superficial and the deep layers can be separately visualized. And next is, since there is no leakage, you get a good quantitative analysis, which is important for research and clinical trial purposes, etc. If you look at the layers of the retina, you can see there are certain capillary plexus intermerged between these layers, and these are the layers that are actually segmented and studied in OCTA. The first two layers, the superficial capillary plexus and the intermediate capillary plexus, together form the superficial vascular complex. Then you have the deep capillary plexus forming the deep vascular complex. It is the deep plexus which is more important, because most studies have shown that ischemia of the deep vascular plexus is more associated with diabetic macular edema and the ischemic maculopathy. Now, OCTA is an optical imaging technique. It is motion sensitive, so inherently it is associated with a lot of artifacts. Particularly in DME, because there are cystoid spaces in the retina, segmentation errors are very common. As already mentioned, one of the important reasons why we cannot assess the perfusion clearly in an OCTA is because of the segmentation errors. When there are segmentation errors in the segmentation created by the machine, we may have to manually correct it. Once the segmentation errors are corrected, what we are looking for mainly is the foveal avascular zone. Then you will have to differentiate between a cyst and a non-perfusion area, because since there are a lot of cysts, the cyst can cause mechanical movement of the vessels, the displacement of the vessels, and it can also shadow the underlying structure. So a cyst can appear as a non-perfusion, leading to a spuriously high FAZ value. Then microaneurysms are also important. I'll come to that. Now, regarding segmentation errors, it is a frequent artifact in macular OCTA images of DME. Manual correction of segmentation errors has been shown to significantly affect OCTA-derived measurements. However, manual delineation of all B scans is time consuming and it is not feasible in clinical settings. So, what is the solution we have? This is one study in which they have studied the segmentation errors. What they have found is most of the errors, they occur at the level of the inner plexiform layer. So if you can manually correct the inner plexiform layer at the foveal center and apply it to the rest of the scan, you can correct most of the errors associated with segmentation. So what they've concluded is that manual segmentation of retinal layers, particularly the inner plexiform layer at the foveal center, gives reasonably accurate OCTA measurements such as vessel density and foveal avascular zone area in clinical settings. However, this is not applicable in a research or trial situation where you need accurate measurements. Now, in the left side picture, you can see the blue line corresponds to the automated segmentation generated by the machine. You can see that it is cutting through the cyst. It is not correctly aligned along the inner plexiform layer. The other picture, you can see we've manually segmented and aligned it along the inner plexiform layer. The difference it makes is, this is the OCTA image that is generated by the first segmentation. The foveal avascular zone in the deep capillary plexus is what I've shown. After manual segmentation, there is a considerable decrease in the foveal avascular zone. So that helps us to correct some of the errors that are caused by segmentation. Now, once you've corrected the segmentation errors, you're looking for the parameters on FA. Some of the machines give automated measurement values. In some of the machines, you will have to do it manually. Advantage over FFA is that you can assess it both in the superficial and the deep vascular plexus. In FFA, primarily, you are able to see only the superficial plexus. Now, what are the main parameters you are looking for? First is the FAZ perimeter. That is a line drawn along the innermost aspect of the vessels in the perifoveal area. The area within this perimeter will give you the foveal avascular zone area. Then there is something called the circularity index, which is derived from the longest horizontal and the vertical diameters at the FAZ. It actually gives you an indication of how circular the fovea is. Several studies have shown that even with normal foveal avascular zone area, loss of circularity or irregularity of the FAZ is a sign of impending ischemia. Then other vessel parameters like vessel density and mean vascular flow density, that is based on the perifoveal vessels in the foveal area. Now, how do you differentiate between a cyst and a non-perfusion in an OCTA image? Now, a non-perfusion area typically has an irregular outline and it is bounded by the surrounding vessels. The inner aspect of a non-perfusion area, rather than being black, it is light gray. Whereas a cyst is a regular ovoid structure and the inner aspect of a cyst is black rather than a light gray. So this you can when there is a segmentation error and you are actually cutting across a cyst, if you see these regular ovoid spaces, you can assume that it is cyst and not an actual non-perfusion area. Now, microaneurysms, generally low flow microaneurysms are not detectable on OCTA because it is based on the flow of blood in the blood vessels. However, perfuse microaneurysms, which are hyperreflective or high flow microaneurysms, can be detected in OCTA. And these are the microaneurysms that are actually associated with an increased risk of localized edema and even ischemia. Now, this is an interesting study where they've studied the OCTA angiography of DME and its association to treatment response with anti-VEGF agents. They actually classified the patients into two groups, responders and non-responders. This is an example of a responder. You can see the left side OCT image is the pre-injection, right side is the post-injection, and they actually measure two parameters, that is the foveal avascular zone and the microaneurysms identified on OCTA in the superficial and the deep capillary plexus. This is the superficial, this is the deep. Okay, and these yellow circles are actually the microaneurysms detected on OCTA. This is a microaneurysm. Non-responder group, again they've studied the superficial and the deep plexus. What they have observed is that this is again the foveal avascular zone. The left side image is the responder group, the foveal avascular zone, and the non-responder group, the irregular foveal avascular zone. What they have identified is that in all patients with DME, whether they are responder or non-responder, there were more microaneurysms, larger area of foveal avascular zone, and lower mean vascular density in the deep vascular complex compared to the superficial vascular complex. In addition, what they've seen is that in non-responders, more microaneurysms, larger FAZ, and lower mean vascular density were more prominent in the deep vascular complex, but the difference in the superficial vascular plexus was not significant. So, which means ischemia and non-response are all associated with ischemia in the deep vascular complex rather than the superficial. Now, to take home, though we speak a lot about OCTA, we should understand that it is not a mandatory investigation in all cases of diabetic macular edema. Vascularity of the deep vascular complex is an important prognostic marker, and the best way to assess the vascularity of the deep vascular complex is OCTA, provided it is properly captured and systematically interpreted, and it is a valuable tool in estimating the visual prognosis and helps in decision making in case of non-responders. Thank you for your patient listening.
Thank you, Vineetha. So, any questions?
OCT or OCTA. In a busy practice, very often we do not have time to go and check. But like Madam said, all that segmentation is very important. And scrolling through the images that's been taken helps us to identify a lot more things that we might miss by just looking at a final printout.
In fact, the morphology is more important than the quantitative analysis. So most often we look at central macular thickness. It is actually overestimated, but morphology of the edema will be more important. The biomarkers are more important than the actual measurements.
Definitely, this Octa proper evaluation is time consuming. So probably one situation where I use Octa in my diabetic patients is when the patient is not having any macular edema, either before treatment or after treatment, and I cannot explain the loss of vision. So when there is a lot of cystoid spaces, you are definitely going to you are not going to properly interpret the amount of ischemia. Maybe more this machine learning, deep learning, everything will come out with an answer for this.
Especially in those patients, with most of those patients, actually the creatinine levels are so high, and it is so cumbersome. Actually, you have to send the patients to the nephrologist and all, and one way or the other, they are always against us with injections and all. And what to say, that with angiogram itself, they'll tell like it's better not to. So this is actually, it's a boon for such kind of patients. Okay. Uh, any other questions?